So we're moving on, I guess, to another kind of collaboration, which comes from the field of epidemiology. And as Dr. Seshrati shares her screen, she really is almost synonymous with the Framingham heart study, but she's gone south, maybe from the cold winters of the Boston area or the New England area to now continue her work at San Antonio. Dr. Seshrati, we're delighted to have as part of the VASCOG community because she's really a leading exponent of the epidemiology of stroke based on many important learnings from the Framingham study. And I think it's a nice segue to what we've just heard about multi-site collaborations and multidisciplinary interactions, because she's going to talk to us about the variation in global burden of stroke and the influence of clinical and brain VCI phenotypes and what the implications are for prevention. So it's bringing together epidemiology and actual clinical and in a more deep way, clinical and brain imaging phenotypes, which was added to Framingham at a certain point and has really enriched our understanding of longitudinal change across different generations. So thank you very much, Dr. Seshrati, and over to you to enlighten us on this really very important topic, especially in the current era of the COVID pandemic.
Thank you, Professor Black. I find that my screen sharing is disabled. I'm so sorry, I just noticed that.
Well, we can see you, we can see you.
Can you see my screen?
Well, we can see your slides.
You can see my slides?
Yeah, very, very nicely. Yeah.
Okay, great.
Maybe you can't see your slides, so you're going to have to memorize your talk.
I'll be okay. Thank you.
Okay, good.
So to be honest, I agreed to speak because I wanted to be part of VASCOG. It's such an honor, and I've learned a lot more than I'm probably going to impart by way of wisdom. I had to miss some sessions. As you can see behind me, the sun is just rising. And I literally feel like I'm carrying coals to Newcastle because there are people on this call like Rufus and Swarna and you, Professor Black, who have done a lot more. So I was asked to speak on the global burden of stroke and influence on clinical brain VCI phenotypes and the implications for prevention. And as you kindly alluded, my experience has been in white persons in New England and a population that was an immigrant population in 1948. About half of them were new immigrants, but over the generations is a somewhat privileged population. So a lot of my collaborations also have been transatlantic in North America and Europe, and primarily driven by a desire to have a large number of people to study and look at variation within this population, not truly to the extent it could be a global. So, but I will be speaking today about variation in global burden of stroke, including data that's not ones that I've generated, alluding to temporal trends and social development indices as determinants of this variation, of stroke, as we all know in this, being the tip of the iceberg, and what lies below the water in terms of global variation remaining largely unknown, the close link between stroke and VCID and its determinant as a determinant of dementia trends. And finally, I guess the most important part, how this could shape our approach to population and personalized prevention. So in 2014, when Claudia Sitisabal presented this, and in 2016, when it was published, it was interesting to note that over the 4 decades of data in Framingham, there had been almost a 44% reduction in an age-specific risk of dementia, and that the mean age at which Framingham participants were developing dementia had gone up by 5 years. Some years previously, we had said that a 5-year increase, I think this is sort of going on auto, a 5-year increase meant halving the risk of dementia. We didn't have data on race ethnic minorities at that point. Since then, there is data from other minorities in developed countries. There is much less data in countries, middle income like China and India, but possibly there is not as steep an age-specific decline. But of course, in all countries with the increasing life expectancy, the total burden of dementia is increasing. But when we looked at what might be underlying the decrease in age-specific incidence in Framingham, the major factors were better control of blood pressure, stroke, atrial fibrillation, and so prevention and treatment of stroke. And by treatment of stroke, the most important factor seemed to be prevention of recurrent stroke. Try to move on to the next slide. Apologize for that. So the global burden of stroke data has shown that age-specific incidence of stroke, that's much less controversial than incidence of dementia, is decreasing globally. Not as much in younger adults. We had a Framingham paper by Hugo Aparicio, and there are other papers as well. And the overall burden of stroke, of course, is increasing as the population increases, with age-adjusted incidence rates, as you can see here, red means higher, blue means lower, being higher in LMEC countries. Why is it not? Somebody help my, okay. And we know that outcomes after stroke vary with patient factors like older age and female sex being associated with about 20% greater risk of dementia, presence of other injury, and this is likely because of covert brain injury, presence of hypertension, diabetes, atrial fibrillation, and previous stroke, worsening outcomes. And the very important but poorly understood factor of the reserve in the brain at the time of the stroke. This could mean education, but it could mean nutrition and other things as well. The stroke characteristics, like the dominant hemisphere strokes, the size of the infarct or hemorrhage, the location, whether it's an infarct or a hemorrhage. And finally, as I've been mentioning several times, the amount, the setting in which the stroke occurs, which determines the reserve, things like white matter hyperintensity. More recently, when we are talking of younger people, DTI measures, hippocampal volume, and a comprehensive, in that sense, global burden of small vessel disease. But it also varies with the social and medical support systems in a place, like whether there are stroke units, whether people reach in time to get TPA or intervention, whether antiplatelets are administered, and secondary prevention. We do find that there is some difference between hypertension is the cause of stroke, and therefore we see ID. But in LMEC countries, clearly, also in other countries, there are data from the Northeast, from Brigham, that shows that air quality increases stroke risk, from Framingham as well. But the places with the worst air quality are in this tropical region with LMEC countries. And you can see the steep increase with increasing air particulate matter in the hazard ratio for stroke. And this is data from the PURE study. So if one looks at population attributable risk with different conventional as well as novel stroke risk factors, you find that hypertension is a major cause across all geographic regions, as is obesity and glucose intolerance. But some that are more important in certain pockets of the world include things like household and ambient air pollution, diet, and smoking. But interestingly, if you look at what is the trend in the population attributable risk, you find that whereas hypertension, obesity, and glucose intolerance are becoming more important in all countries, the others are improving in all countries, although not at the rate that one would like, because clearly these are addressable factors. So when one considers that stroke is just a warning sign, so to speak, of a long-standing factor. Everyone in this audience knows that we don't call stroke a cerebrovascular accident because it's not an accident. It is the inevitable consequence of exposure to a variety of risk factors, resulting in covert vascular brain injury. There's much less that's known about global variation in covert vascular brain injury. There is emerging data from LMIC countries, but particularly when we think about trends, because most of this data is fairly new, there is much less known. But we do need to recognize that this covert injury is a determinant not just of current blood pressures or other vascular risk factors, but of exposure over time and of another unknown factor, that is the susceptibility of that individual. And so some unpublished Framingham data, if you look at 8,000 people followed for 14 years, and you use the ESC, ESH definition of hypertension-mediated organ damage across 4 organ systems, you see that people who have grade 1 to 3 hypertension, if they have hypertension-mediated, what used to be called target organ damage, their cumulative incidence of CVD or stroke is so much higher than if they have the same 1-point blood pressure, but the target organ-mediated damage is less. And so risk stratification clearly requires awareness of this information. So some geographic variability is well known in, say, intracranial lateral, but much less is known about covert CSVD. There's some data from Bangalore, for instance, saying that risk factors may be slightly different, but that's not yet, I think it requires further examination. So if we think about what this implication would be for dementia trends, the global burden of disease estimates of dementia are a lot more controversial. Dementia is a harder endpoint to be certain of because you're assessing cognition that depends on so many factors. So I wouldn't necessarily say that some of these blue countries have less dementia. But one interesting thing is if you look at the global burden of dementia and compare it to the same global burden of disease estimate of burden of stroke, you find that, you find that they overlap to some extent, right? The pattern of where there is more stroke, there is more dementia, and where there is less stroke, there is less dementia, and implying clearly that this is partly driven by the post-stroke VCID component of all-cause dementia. So how would we then look at prevention of VCID with this background information? How does this inform us? We know in this audience that what's good for the heart is to some extent good for the brain, though perhaps not exactly in the same doses and at the same time in life. But the AHA Life Simple 7 in the 3C study, people who had everything in the optimal range had a much lower decline in their cognition as compared to people who had none of these 7 factors in the right range. And so there is some consensus about blood pressure control and physical activity and education as potentially protective for dementia. And the jury is, however, still out because studies like MACT and Finger and Prediver found more subgroups that had benefit. And the Finger study is now being extended worldwide. And so we'll have more global data, but that's not in yet. And so although it seems, we are telling everybody, we really don't know what doses and when. And we also don't know who might be the people who benefit. There might be subgroups. It could be as simple as people with hypertension or white matter hyperintensity are the ones who benefit most from multi-domain intervention, but it could also be more complex and determined by their individual genetics or other factors.
Actually, Dr. Shradi, if you just say next slide.
Okay.
Go more smoothly. Okay.
Okay. So we have, but I thought I'm showing my screen. But anyway, so Dr. Peloso in our group looked at the impact of improving cardiovascular risk and found that even in people who have high genetic risk, if you improve cardiovascular risk, there's still a 50% lowering of the overall risk of dementia. So genetics is important, but not destiny. Next slide. So at the same brain volume, so just some novel factors, cognition was better with someone to talk to in Framingham. So let me explain here. If we looked at people, the relationship between brain volume and cognitive function, you found that those who had low listener availability, for every unit decrease in brain volume, there was a 4-year equivalent of brain aging in terms of cognition. But with listener availability, this was only about a quarter of a year. Next slide. Again, another sort of slightly surprising finding. Andrea-Ann Beryl looked at nearly 500 people who had had a PSG done overnight as part of the sleep heart health study, and then an MRI brain, and found that less slow wave sleep, this part is not surprising, was associated with higher white matter hyperintensity volume. This is consistent with slow wave sleep being important for amyloid removal. But among people with high apnea-hypopnea index, we've always had this slight controversy about sleep apnea and dementia, although the association with stroke seems clearer. We found an association among people with low IL-6. Next. It's not the next slide. Yes, IL-6 may promote hippocampal neuronal differentiation. So, of course, we know there's good inflammation and bad inflammation. And here, this was an interesting thing about IL-6. This is circulating IL-6, not in the brain. Next slide. So biomarkers like this can be tools to explore biology and thus predict a person's individual response to preventive interventions, as well as track the response. Next slide. So some of the studies that are attempting to do this in the US now that I'm part of, and hopefully we'll have results in years to come, is MARC-VCID that has finished 5 years, identified certain MRI imaging, OCTA, blood biomarkers, and during the next 5 years, we'll be refining these as potential biomarkers in VCID trials. This is a good complement to the European effort, and several of the people on this call are advisors to MARC-VCID. Discovery that began recruiting this year, acute strokes, 8,000 strokes, with a great emphasis on African-American Hispanic populations, and we'll follow them for 4 years for cognitive function, still struggling with sort of separating out post-stroke cognitive impairment and dementia with truly progressive dementia, but we'll be looking at biomarkers, genetics, epigenetics, MRI, and also PET, because this speaks to, next, the component that VCID is often a contributing factor, one of perhaps along with amyloid and alpha-synuclein that's causing dementia. And so one does need to have that background. And of course, VCID has so many etiologies, most obviously small and large vessel disease. And so that heterogeneity has to be accounted for as well. Next. Another study that's just begun is called Diverse VCID. Again, the emphasis being on relating the progression in white matter injury to cognition, both in terms of amount of white matter injury, location of white matter injury, as well as a list of biomarker and epigenetic and genetic factors. and including a more diverse population led by Charlie DiCarli and Miriam Fornage. The discovery PIs are Natalia Ross and Steve Greenberg. Next slide. So another way is using these newer tools like omics to try and understand the biology of why something like physical activity may be good for preventing BCID. And for fish intake, we suspect it's, the omega-3 fatty acids. But this suggests that for physical activity, lack of physical activity may be increasing levels of things like glutamine that are associated with decreased cognitive ability. Next. So when we are talking about a global perspective, though, next, there is, of course, individualized prevention strategies, but those are impractical on a global scale. The cost-benefit ratio may also be greater with population prevention strategies. Next. And so how can one do this? Will Whiteley had a nice review of our large simple trials for dementia prevention possible. And clearly they are. If we all recognize that hypertension is the predominant risk factor for stroke and BCID, and this study by Tommy Wang in New England Journal 2 years ago showed that a polypill usage reduced systolic blood pressure by 9 millimeters of mercury compared to 2 millimeters of mercury for usual care. The cost for 10 years being to treat one person for 10 years being the equivalent of one amyloid PET scan. So if we can, in parallel with individualized prevention, next slide, or just next, consider using simple definitions of higher risk and longer periods of follow-up for outcomes, pragmatic intervention studies like Preventable, which are looking at statin use, or adding on a cognitive arm to other trials, which is happening, is clearly a way forward. And we do this in other things, right? We use fluoride in the water as well as visits to the dentist for prevention of, say, caries. Next slide. There is, of course, this wrinkle that has been thrown on the world since 2020, that is COVID, and what is going to be the impact for both stroke risk and longer-term stroke risk, not just during the acute illness and for subclinical disease. And there are some efforts ongoing. The Alzheimer's Association is leading something, as well as the C4R2 is a consortium of 14 cohorts like Framingham, which have all by telephone and serology determined whether people have COVID, and is now going into a C4R2 phase where brain and other target organ damage will be looked at, including by MRI, including 3 and 7 Tesla, DTI measures, MRS studies. And C4R is one component of a large billion-dollar effort, the Recover cohort, which should soon be announced and should likely have between 15 and 20,000 people across about 14 sites, all ages, that will be looked at for multiple things. Some unusual aspects of COVID seem to be its impact on the olfactory system, as well as its impact on autonomic function, which may account for sleep disturbances, fatigue, orthostatic hypertension. And so imaging the locus ceruleus also is a component of some of these efforts. Next slide. We know that overall in stroke, in COVID setting, it's the older people with risk factors who get stroke. But if you compare strokes in COVID, not in COVID, you have other things like large arteries, infarction, and venous thromboembolism. So in summary, stroke is a major risk factor for dementia, and stroke risk factors and outcomes vary with age and social deprivation indices. The covert vascular injury is very important, but variability across countries needs to be better understood. And effective prevention of stroke and BCID will likely require both population and precision approaches. Thank you. It took me about 3/4 of the talk to figure out that I was not the one controlling the slides. So I apologize for that. And I look forward to learning more. Just a shout out for the last 5 years, my colleague Stephanie DeBette and I have been privileged to host some of our brightest colleagues in neuroepiomics meetings, and there'll be one in October as well. Happy to share more details for those who are interested. This is in 2019, pre-pandemic. And of course, since we are in Texas, we're trying on our hats. Thanks.
Well, thank you for that wonderful overview. We, I guess we only have maybe 5 minutes or so. I don't see any comments in the chat. I think people are a bit overwhelmed by the combination of this global world situation we're in with COVID and stroke and slow or long haul. And we've seen that COVID gets in to the olfactory system and the limbic system in some imaging we're doing. It's pretty unsettling. And then you've got climate change and pollution, a contributing factor, right down to the individual person. I think, that observation about loneliness is such a profound insight also into the human condition. So you've got all these global events happening, and it comes down to sometimes, do you have somebody you could talk to, which is really a big issue, with the all the restrictions to do with COVID. So thank you for that wonderful overview. I mean, it's just like fascinating and terrific studies that are underway to help us understand this. But are there any specific questions to Dr. Seshadri or any comments from the audience? Now's your chance. They're stunned. So I'm just wondering, Sudha, especially the pollution issue with climate change and, in North America, and I think all around the world, I mean, there are disasters, but also pollution from fires, forest fires, and destruction of whole forests in Australia. And now in North America, we've been suffering in Canada, tremendous, wiped out a whole city, little town in northern BC. And then the pollution, again, as a reminder of the how we're all one world, the smoke and particulate matter floated across Canada and started to even go down towards the city of Toronto, which is 6 million people. It's the largest, kind of city in Canada. And there were sunsets where the sun was a red ball, and you could actually look at it without sunglasses. I mean, it was kind of scary because it was filtering out the rays. And it was a reminder that we really are all one world. And we got to take care of ourselves, or it is really going to be very disastrous. On the other hand, the poly pill shows that, I think that's a favorite USEF kind of comparison. 10 years of prevention, and that's worth 1 PET scan. So we really have this rich and poor nightmare that we're facing. We have areas of conflict. We have climate change. Do you have any wise words in the last couple of minutes about, where we should go from here, and how do we make sense of all this, and what can we do?
I don't know about wise, but one of the emerging approaches, as you know, is trying to integrate these multiple non-genetic factors into an exposome. I'm not completely sure how valuable that will be, but colleagues in different universities are trying to do that. So again, there's this, I guess, inherent tension between few simple, clear solutions that we implement. We went to NIH for a continuation to the 39th year of the Framingham stroke study and increasing diversity. And we had a rather pungent comment that, we don't need to know that hypertension is a risk factor for stroke in diverse communities. We need to know how to lower the blood pressure in those people. And that was absolutely spot on. So I think both in terms of learning more at an individual level, but in parallel, doing the things we know works in a more effective manner. And, we have people like Swarna and Rufus who are I really feel that some of it is beyond me as an epidemiologist and really in the field of the public health experts now, handing over the baton.
Okay, I'm just going to make one comment that Dr. England brings up the point about now the fact that we're going to have blood tests potentially for the proteinopathies such as tau, synuclein, amyloid, and now we can know about the neurodegenerative proteinopathies. Thoughts on whether our concept of metabolic, metabolism and blood tests, to what extent is that something that you think we may need to factor in? And I think Raj wants to ask one question, but just comment for Dr. England, who's a very
Sure.
venerable pathologist who's seen the results of these proteinopathies over many years.
I think that's absolutely spot on. The hope is that we'll have a blood marker for every endophenotype axis, right? That we are still far from completely understanding that. We have things like NFL that are less specific and are also affected by systemic factors like your EGFR, but it's so much more hopeful than it was 10 years ago that we may be able to take a certain type of tau, maybe p-tau 181, a certain marker of inflammation, a certain marker of neuronal injury or glial injury like GFAP, and then have a picture, so to speak, of this person's in vivo brain injury profile, and then address our interventions to that. See the effect of even simple things like lowering blood pressure on that profile. We have, as of today, I can now say it, we are going to be a South Texas Alzheimer's Center, and we plan to get these kind of blood markers in everybody. So Dr. England, I completely agree. That was amiss of me not to mention that, and you're spot on. I think this is going to be something that's beneficial. Costs are certainly coming down, not in a global population sense, but at least to understand.
The personalized approach. Raj, did you have a question? I think
yeah, thank you.
High compliments. They're wonderful compliments for your brilliant overview, but do you want to finish off, Raj, with a question or comment?
Thank you very much, Sudha. We thought we'll give you a break with the early morning in San Antonio and change the slides for you. But the question, air pollution. I mean, this is an interesting, factor that has come up more in recent years. Did the Framingham study, first of all, look at air pollution as such, or are there any reliable data, I would say? And what might be the pathophysiology? I mean, probably it has, those little particles have probably many, many effects.
You're absolutely right. There's everything from, there is in fact a Framingham paper looking at PM 2.5 with relation to subclinical measures as well as not dementia risk, but stroke risk. There's also the paper from Brigham that I think got a lot of press, looking at day-to-day variation in pollution levels and relating that to acute ER visits. So at one level, this is increasing atherosclerosis, and maybe at another level, it's also increasing plaque instability and acute events. There are also data in Framingham, actually, and somebody is looking at this on, say, lead levels over time, because we know that in the US, for instance, the amount of environmental lead has changed. And so in some developing countries, this is still unfortunately far too high. So everything from, nitrogen oxides to ozone to heavy metals clearly are all things that could be looked at. And I'm not the expert to answer why, but I agree with Sandra that we need to look at these trends, and those studies that we have, Monique has, where there's information over the years, we can see if in the last, as climate change increases this air quality issue, is it increasing stroke or VCID?
I can see that Dr. Beasels is getting a little anxious to get started in the next session. So thank you for just a wonderful overview and very thought-provoking and, precision, personalized medicine versus global situation. It's a it's a great dilemma because we're so aware of all of these factors now, and we're living through a period of history that's pretty challenging. So on that kind of profound note of challenge to us all as human beings, over to Dr. Wiesels.